Hello, my name is Casey and I'm a student physical therapist at Campbell University, and today I'm going to talk about the Talocrural J-whip. So first, before we talk about the manipulation, we need to talk about what normal is. In Wise's textbook, he says that normal motion of the talocrural joint allows for about 34 to 50 degrees of plantar flexion and 10 to 20 degrees of dorsiflexion. The capsular pattern of the TC joint is plantar flexion is more limited than dorsiflexion normally. If this joint is limited in dorsiflexion, it can have functional limitations related to gait. Normal gait requires the tibia to translate anteriorly on the talus. If there's a limitation in this, then the tibia will not be able to translate anteriorly, resulting in compensations. Regions of hypo and hypermobility may compromise the ability of the foot to perform important functions, causing pain and disability. To determine the difference between true talocrural joint restriction and gastroc tightness, it's important to look at the quality of dorsiflexion with the knee flexed and the knee extended. So measuring dorsiflexion and weight bearing provides a more reliable measure when you try to translate it over to function instead of having your patient lie supine on the table. In a study by Fryer and his colleagues, they show that those who experienced a cavitation with talocrural joint manipulation showed greater improvements in dorsiflexion range than those who did not have a cavitation with the manipulation, or those in the control group who with no intervention. Although these numbers did not reach a statistical significance, the greatest improvement in dorsiflexion range was with the manipulation and cavitation. In another study by Lopez Rodriguez, they assessed how the talocrural joint manipulation would affect stabiliometry and baropodometry in the athletic population with grade 2 lateral ankle sprains. So what they found was actually no significant change in stabiliometry. However, they did find greater changes in the redistribution of the pressures within the foot after the talocrural joint manipulation. The authors explained that this will aid in resetting the load distribution within the ankle, alleviating structures from inappropriate loading. So in order to do the talocrural J-whip manipulation, first we want our patient supine on the table, and we want her to remove her socks and shoes. Can you do that for me? So for this manipulation, it is a HVLA, a high velocity, low amplitude manipulation. So first what you want to do is make sure the table is an appropriate height for you and use good body mechanics. Next, you want to use your thumbs to dorsiflex the patient's foot. You want to cross your middle fingers over the talocrural joint and then interlace the rest of your fingers. So you're going to dorsiflex with the thumb, and you are going to apply a traction force that's inferior, and then when you apply the manipulation, you want to do almost a scooping motion. So that's going to look like this. And that is a talocrural J-whip manipulation. So what we found was a lack of dorsiflexion in your ankle. And what that is just when you pull your toes up towards the sky. So what we did was a manipulation, and that's a high velocity, low amplitude thrust, what we just did on you. So what we hope that will do is increase your dorsiflexion range. So we'll give you a couple more exercises to follow up with at home, like stretches, to maintain that range. And we hope to increase it over time as therapy progresses.